presentation. And now we're going to be moving on to Dr. Katerina Gousia, looking at the impact of diabetes on the use of long-term care. So if you'd like to take a few seconds to introduce yourself, I think that would be great. And then please feel free to start.
Thank you. Hello, everyone. My name is Katerina Gousia. I'm a researcher at the University of Kent, and together with Quintara and other researchers from the University of Kent, I've also worked on ASCRU and more specifically the risk factors project team. So I'm gonna start sharing my screen and start sharing the slides.
Yes, we can see that. Thank you.
Okay, perfect. Cool. Okay, perfect. Yes, so as I said, with other researchers from the University of Kent, we've been working on a study that tries to understand how diabetes impacts on social care. And today I'm going to present on this work. Before I continue to the main study, I just need to make the usual disclaimer that this work is funded by the NIHR and the Department of Health and Social Care, but the views expressed here are those of the authors and do not necessarily reflect those of the NIHR and the Department of Health. Moving on to the main study, let me begin with providing some background that gives the motivation behind this work. So we know that diabetes is one of the most common long-term conditions in the UK, particularly among the elderly. There's a large number of people currently affected by this condition, and that's projected to rise sharply in the not too distant future. And we know that this has significant implications for healthcare costs. Diabetes accounts for 10% of the NHS budget, and 80% of that is due to diabetes complications. However, we also know that people with diabetes compared to people without diabetes are more likely to have some physical disability with their mobility, ADLs and IADLs, cognitive complications, lower psychological well-being, and sometimes very serious complications such as amputation and blindness, which are likely to hinder their ability to go about their daily lives. So therefore, one can imagine and suspect that diabetes is also likely to impact on social care costs. However, so far, we don't have evidence on what that impact is and how large or small this impact on social care costs is. With an aging population, though, the number of people with diabetes, especially in social care, is more than likely going to grow. And therefore, understanding what that impact, how large or small is, becomes important. First of all, from a policy making point of view, it can help policymakers and economists to project, make accurate projections for future rises in the demand for social care. Consequently, services and local authorities can prepare for these rises, particularly if they serve populations with a higher prevalence of diabetes. And also, if we know what the magnitude of that effect is, we could possibly identify efficiencies we can achieve at different parts of the system, whether that's at the prevention or management level of diabetes. Therefore, the aim of this project is to estimate the effect of diabetes on the use of long-term care, and we differentiate between formal and specifically community social care services and informal care. And ideally, we want to estimate a causal effect of diabetes. In other words, try to estimate the effect of diabetes separate from other factors. So to think about the relation between long-term care and the use of and diabetes, we use a very simple conceptual framework like the one presented on the slide. So for person I at time T using a type of care J, and that would be formal or informal care, we can think of the probability of using long-term care as a function of a set of characteristics of variables, and that we group them into different categories. So the first variable we're interested in, we expect affects long-term care, is having diabetes. Another set of characteristics is what we call as needs-related comorbidities. So any other condition that is likely to affect long-term care, such as heart disease, arthritis, or anything else you can think of. Another set of characteristics that we name here as X is just any other individual level variables that we think can affect the probability of using long-term care. So this could be education, this could be income, but this could be also lifestyle choices such as diet and obesity. And finally, the last group of characteristics that that can affect the probability of using long-term care is anything else that we don't observe. So factors that we cannot measure. So that's a very simple conceptual framework to have as the background. When we go to the data and try to do the empirical estimation, we would like ideally to estimate the causal effect of diabetes. We know that diabetes is likely to be characterized by comorbidities. So someone who has diabetes is more likely to have other conditions such as heart disease, high blood pressure, and so on. And we know that diabetes is also influenced by socioeconomic status and lifestyle choices. Therefore, if those factors are uncontrolled and not accounted in the statistical analysis, then they will be part of the estimating diabetes effect, and therefore producing biased estimates that cannot therefore be used for drawing policy conclusions. We cannot randomize people between diabetes and non-diabetes as we would do in an experimental setting for obvious reasons. Therefore, we have to rely on observational data. And with observational data, some of these factors will be measured, but some will be unobserved. Therefore, the question is, how do we manage to isolate the diabetes effect from the other factors with observational data? And what we use in this study is the empirical strategy we use is the so-called instrumental variable for IV method. I have a very simple graph that people, using this method will probably be familiar with. What we want to estimate is the impact of diabetes on Y, but we know that diabetes is most likely correlated with other unobserved confounders. Therefore, this effect is going to be biased. What the instrumental variable method does is finding another variable, Z, which is the instrumental variable, which is causing some variation to the diabetes, and through that to the final outcome. However, it's exogenous to unobserved characteristics, so this channel is blocked, and also doesn't affect the outcome directly, but only through diabetes, and therefore this also we can block out this channel as well. So within this framework, by blocking out all of these confounding channels, then we can be more sure that the effect of D on Y is distinct from other factors and therefore causal. However, finding a suitable instrument that satisfies these assumptions is also very challenging. In this study, what we use as an instrument is a measure of one's genetic predisposition for developing diabetes, as we believe it's likely to satisfy this assumption. So genes are inherited from parents with an equal probability during conception, so it's put as random. We believe that is highly correlated with someone who has a genetic predisposition for diabetes is more likely to develop diabetes in later life. And we can also assume that the genetic predisposition affects utilization of long-term care only through diabetes and not through other channels. Therefore, we believe that this model here is kind of satisfied. Obviously, these are assumptions. Some of them can be tested and some of them cannot. In our analysis, we run different tests to explore the validity of these assumptions, bearing in mind the limitation that we cannot test formally for all of these assumptions. Gintare talked about polygenic scores as well, so I'll try to be brief. So to measure genetic predisposition for diabetes, we use what is called as polygenic scores, and this is effectively it's the sum of individual genetic load, if you want, for diabetes. So the recent genome-wide association studies have produced a lot of information about which genes, which genetic variants affect the different traits, including diabetes, and what this correlation between the genes, those genes, and the diabetes prevalence is. Therefore, once we have someone's DNA, and we can construct an index of how genetically loaded, let's say, their DNA is, and therefore understand what is their genetic predisposition for developing diabetes. And this is the information we use as an instrument, as a measure of the genetic predisposition. And let's go to the data set that we use, and contains all this information we need. And this is the English longitudinal study of aging, ELSA, the longitudinal biennial survey of individuals aged 50 and more. So ELSA has a wide range of variables at the individual level, and most importantly has the variables that we're interested in. So we know whether respondents have diabetes, we know whether they use formal and informal care, we have information on characteristics like family structure, comorbidity, socioeconomics, and so on. And we also have the polygenic scores for a subset of those individuals. We have 9 waves of data from 2001 to 2017. We restrict our sample to those aged 65 and above, those with a diabetes diagnosis after 35, and these observations with an available PGS score. And that gives us a sample size of something less than 21,000. So our key measures for the analysis are self-reported measures on diabetes and the use of long-term care. So our measure of diabetes is a binary indicator for whether the respondent has ever been diagnosed with diabetes. Formal care is a binary indicator for whether a respondent who needs help with their ADLs and IADLs has received any care from social care services, from that list, whether that's home care, work care, reablement services, member of staff from a care home, day center care, and so on. And likewise, the measure for informal care is again a binary indicator for whether a respondent who needs help with their ADLs and IDLs has received help from either partner, child, grandchild, sibling, other relative, friend, or neighbor. So these are our main measures. And these are the sample statistics for this sample. So about 10% of our sample have diabetes, 7% use formal care, and approximately 23% use informal care. To save on time, I don't want to go through the other characteristics, but the table is there for you if you want to discuss this later. Okay, so we have the instrument. When we go to the empirical specification to estimate the effect of diabetes on the probability of using formal and informal care, we use the extended probability estimator. This model accommodates for the binary dependent variable. So whether we use formal and informal care, accommodates for the binary endogenous variable, which is diabetes, and allows us to estimate an IV setup. Now, another consideration we're thinking about the statistical specification is how many and which additional controls to include. So one particularity of this instrument is that the randomization takes place at conception, and therefore, theoretically, any observed characteristics following that could be affected by that instrument. And therefore, if we control for many of these, for many covariates, this is likely to absorb some of the effect of diabetes that we're trying to estimate. So it's we're trying to strike a balance here between controlling for certain characteristics, but also making sure that we are estimating the causal effect of diabetes. Therefore, our baseline specification, our baseline results are based on a specification that accounts for only a small set of what so-called exogenous characteristics. And those include year of birth, gender, wave dummies, and something called ancestry informative principal component, which is information that is coming with the PGS course in ELSA and allows us to control for possible systematic differences in the genetic distribution, if you want, across different subgroups of the population. So for instance, geographical or based on ethnicity and so on. So once we have the specifications, these are the results. Can you see them?
Yes.
Okay. We have the estimated results for formal and informal care, the marginal effects from two types of models. So we start with a simple probit model for both formal and informal care. And this is the model that does not take into account possible endogeneity bias in diabetes estimates. And then we move on to the eProbit estimation that uses the IV methodology. So we see that in all cases, the estimated effect of diabetes is positive and statistically significant on the probability of using formal and informal care. In the case of the simple probit estimate, this effect is about 3%. But when we move to the specification that takes into account endogeneity, that goes up to 10%. Likewise, for informal care, the simple probit estimate gives us an estimated effect of an increase in the probability of 13%. The instrumented model that takes into account endogeneity of diabetes takes this effect up to 34%. The first stage coefficients and the first stage square give us our tests that we use to understand whether one of the assumptions of the IV model is satisfied, and more specifically whether our instruments of the genetic predisposition is correlated enough, it's predictive enough of our endogenous variable, diabetes, and those and from the evidence we have, that seems to be the case. That's one assumption that can be tested. The other assumptions, however, cannot be tested, as I mentioned, and more specifically, the assumption about whether an instrument affects long-term care only through diabetes and not through other channels. There's no formal test for that. However, we can run some analysis of the data and try to understand whether there's some evidence in the data that don't actually prove whether this assumption is satisfied, but provide us with some reassurance that we are on the good path, let's say. So one way to do that, to understand that, is to see if there's any systematic relationship between your instrument and other characteristics. And so what we do here is we split the sample into two groups. One group of individuals with a high genetic predisposition, and the other group of individuals with a low genetic predisposition, roughly very arbitrarily above and below the median of the IV distribution, and try to see if there's any systematic difference between the two groups on the observed covariates. If we don't see any systematic differences, that's not a proof. However, we can be reasonably reassured that our instrument is as good as random with respect to those characteristics, and then possibly with respect to unobserved characteristics. So what we see when we compare these two subsamples is that in fact the mean across different covariates is very, very close to each other. Estimating the standardized mean difference gives us a difference between the two groups of below 10%, sometimes in some covariates it's below 5%. That is a small enough difference to assume that the instrument is working okay. The biggest difference observed with respect to the obesity indicator, with a standardized difference of 12%. However, it's still not too large and within the range of that we will be willing to accept for this kind of analysis. Next, we move on to running another set of robustness checks. So I spoke earlier about the specification of the model and the number of covariates that we're choosing. Although the baseline specification includes a small number of covariates, we move on to adding additional covariates in order to understand the sensitivity of our results to the inclusion of other observed characteristics. We do this for a number of reasons. Even though it does absorb some of the diabetes effect, it does controlling for some of these covariates and does allow us to control possibly better for omitted variables bias. We can use it as an indirect test to see whether our instrument is possibly correlated with some of these characteristics. And we can understand whether some of these covariates work as possible mechanisms of the diabetes effect. So we have three main additional specifications, and what we do is build gradually on the original
Sorry, Katerina,
model.
you have 2 minutes.
Okay, so stepwise, we're adding measures on supply of availability of informal and formal care, of socioeconomic and comorbidities, and lastly of obesity. So these are the models, each model for each type of formal care. What we see actually is that the effects are not too sensitive to the inclusion of additional covariates. When we include measures of availability of care, and then additionally of comorbidities and socioeconomic variables, the effect of formal care is practically unchanged, while the effect of formal care on informal care slightly drops in the second specification. The biggest change we observe it when we additionally add the obesity indicator, but even in that case, the results did not change massively, and it only drops by 1 percentage point in the case of formal care, and the effect is still statistically significant and positive, and it drops by 4 percentage points in the case of informal care. So I guess what this means is that we can be reassured that the effect that we are estimating is not too sensitive to the specification we use. We can trust enough our identification strategy, and even if we want to control for obesity, then we have a lower bound estimate that partials out this effect. And this is what I include in the discussion. So our analysis shows that having diabetes predicts a 10% higher probability of using formal care and a 34% higher probability of using formal care. When we partial out the mediating effect of socioeconomic factors, comorbidity, and obesity, diabetes now predicts a 9% higher probability of using formal care and 27% higher probability of using informal care. And these estimates are a lower bound of the estimated effect. The direct and indirect tests that we have run can give us enough reassurance that the instrument works well and satisfies the assumptions for identification, and therefore we can treat these estimates as close as possible to causal. So future steps. I just want to draw the attention that it's still work in progress. So please treat these results with some caution. We want to run some further sensitivity analysis, whether by different subgroups or test different estimators and specification. And finally, the last step we want to do for this piece of work is to analyze what is the impact on costs. So we know the impact on the utilization, and now we want to estimate what that implies in terms of monetary terms. So thank you very much. If you have any questions or other issues, you can email me or any other member of the team. I'll stop the screen sharing now.
That was brilliant. Thank you very much. Yes, so as before, please feel free to either type questions in chat or raise hands virtually, or otherwise unmute yourself and ask any questions you might have. There was a question that Peter added into the chat, I think partway through the presentation, where there was a figure of 4.7 million that was presented, and he was wondering if that relates to 2023.
Yeah, it's a current estimate. Could be a year before. I'm not sure. Yeah, like a couple of years old. So perhaps we need to update that.
Great. I had one question, just wondering if well, I suppose there might not be data to analyze these separately, but I was just wondering if we might expect a difference between type 1 and type 2 diabetes in terms of impacts.
Yeah, I didn't mention that. So in the data, we cannot differentiate whether people have type 1 or type 2 diabetes. The polygenic scores in ELSA refer to type 2 diabetes. What we have in ELSA is information on the age of their diagnosis. And therefore, we choose to analyze, to focus on the subsample of people that have a diabetes diagnosis after the age of 35. The number of people with a diabetes diagnosis before that is very, very small in the data. This is a survey of older people, so the likelihood is that it's type 2 diabetes. We're working under this assumption, but we don't know it for a fact. Yeah.
That makes sense. So Chiara has a question.
Yeah, I had a similar question about whether it was type 1, type 2, both. Do you want to take a minute to comment on policy implications of this work, maybe?
So yeah, the one obvious policy implication is that with the increase in prevalence of diabetes and in communities where or areas or regions where diabetes is more prevalent, then this is going to translate in an increase in social care costs. I think the next policy implication that we need to work on is whether there is any efficiencies we can achieve based on that estimate at a different stage of the diabetes management. So whether it's by you're going to save more by investing in the management or prevention of diabetes. So yeah, I think this is the result we're going to present next.
Great, thank you very much. Are there any other final questions? If not, I'd like to thank you again for a wonderful presentation and